Hey guys, welcome back to The Pathway. It's Taylor Henrik here. I'm here with my co-host Sarang Patel.
Hey guys.
We're going to take some time today and we're going to talk about the PA profession, introduce to you some of the roles that we have within healthcare, and then talk about how we're trying to make a difference in mental health care. Let's dive in.
Brr, 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 brr.
Hey guys, honestly, I'm excited today. I'm excited to talk about this. This is something that hits home close to us, right?
You're excited every day.
I'm excited every day.
Yeah, you
I
are.
get to work with you. I get to do something with my best bud.
Hey.
We're just tackling stuff on a day-by-day basis, trying to affect a positive change. I know I say that a lot, but in reality, what it boils down to for you and I is making a difference, right?
Mm-hmm.
You want to do something that nobody's ever done.
Yep.
I'm right there with you.
Let's do it.
Let's make the difference. Let's be the difference you want to see in today's world. It may sound cliche. It may sound naive. That's fine. Call us cliche. Call us naive.
Rudimentary.
But are we making a difference? I firmly believe we are. For those out there who don't know, we are both PAs, okay? We are not prior authorizations.
Aye.
We are physician assistants, all right? Physician assistant, right, is the way that it's classically termed. Recently, legislation is pushing through that it's physician associate, all right? For those who are not educated on the matter, the scope of practice is remaining the same, but the role itself or the designation is changing. And so what's happening right now is bylaws are being rewritten. Everything in the mental health, not only in mental health, but in healthcare in general, is being reclassified for our specific designation and occupation as physician associate.
Mm-hmm.
But let's just briefly touch on, let's take a couple of moments and talk about what is a PA, how do they fit in the schema of healthcare, and how do we support other individuals and work in collaboration with other healthcare professionals?
I'm not sure.
Okay.
Enlighten me.
Okay. Well, very good. Your classical interdisciplinary team has your MDDO, right?
Mm-hmm.
Who may be your attending, your collaborative physician, your supervisor, etc. Scattered amongst them or with them on a collaborative team will be your APPs, Advanced Practice Practitioners, formerly known as MLPs or mid-level providers. I think Advanced Practice Practitioners is a little bit more apt and a little bit more consistent with what we're able to offer. In this realm, we work in collaboration with physicians and other mental health care or other healthcare professionals. I keep saying mental health care. I apologize. Working also in collaboration with us will be a number of individuals such as RNs, LPNs, BSNs, pharmacists, nurses aides, patient technicians, care coordinators, social workers, unit clerks, amongst many other members of the team. I may have left some individuals out, but I hope that that gives you an idea of what that team looks like. So where does the PA fit in? In a former life, when I worked at the hospital, I was a part of a hospitalist team. So we took care of admissions. We handled what came in on the floors. We took care of discharges, maintaining care while they were there, rounding on clients, okay? Typically rounding, you'd go and see your clients, write notes, work with their specialists, make sure that everything is all in the right place to make sure that the client's doing well while you're there, okay? My role was one of many different things throughout the day, whether it was, again, rounding and seeing patients, handling new clients coming in or new patients coming in from the ER, or working in coordination with the MD or DO that I was assigned to that day. In the outpatient setting, a PA may have their own clients or their own caseload that they maintain. And again, I don't mean to digress, but just trying to paint a picture of the different settings that we work in within healthcare. And so we have a clear understanding of what does the PA do, and then we'll move into what does a PA do in mental health care.
Yeah, we'll talk mental health care just because I think if you don't focus on a particular category, there's too many variables.
Get lost in the weeds.
Yeah.
Okay.
So I think if you look at the mental health care aspect of it is that initially, right, it's created as an extension to provide access to care. So I think when you lobby for laws to pass through for rights for particular clinician types, we always talk about, does it actually improve access to care? So the PA model, right, initially was created on the medical model, right, different than the nursing model, but the medical model, which is the same medical model that the DOs, MDs are trained on. The idea was find the differential diagnosis, treat the patient appropriately, same kind of concept, but to be an extension of MDs and DOs because of the lack of access to care, right? So you work in collaboration with to then improve quality of care, improve the quantity of care, and then hopes both of them obviously together. So that's kind of where we're at here in mental health, right? We can prescribe, we can diagnose, we can treat. Again, the limiting factor is what insurances say, less of what laws say, but more of what insurances say per state, which makes it more unnecessary and more complicated than it should be. But ideally, you have a collaborative physician, you collaborate with them, whether MD or DO. I think the preferred model by insurance companies is board certified, and then you work hand in hand to then improve, a clinic that could be seeing or an outpatient or whatever practice that would say 1,000 patients, let's say. Now you add in some PAs, you may be able to see 3,000 patients. So financially for the clinic, it's obviously better in that sense, but also for the community around there, you're now getting quicker access to care, which is what the goal is.
Absolutely. This is where the old term physician extender used to be utilized, and I think that kind of was an umbrella term that pinged both nurse practitioners as well as PAs and probably other advanced practice providers. But I totally agree. I think that many MDs and DOs have adopted this model, and you've seen a burgeoning in our field, right? It's universally known as one of the better careers in healthcare, and it's rated as such on many nationwide metrics and scales because there's good quality of life, right? You're able to do your work. You're able to take it. It doesn't necessarily have to follow you home. You have good work-life balance. And PAs have a lot of legislative ability. They have a lot of scope of practice. They're able to do many things autonomously while also working with somebody else who can offer support and be there so you can learn under their tutelage.
Yeah, I think the idea behind it is that it's not supposed to be, when you talk about earlier, like mid-level provider, that kind of says and implies that there's mid-level quality of care when it's really not.
Correct.
Do I think there should be collaboration? Yeah, for sure. I think that PA should collaborate with other PAs, also with physicians, MDs and DOs across the board. I think they should work together as a team. I think that some PAs add value to MDs and DOs, maybe better follow-up times, maybe better, some would argue better bedside manner, but vice versa. I think that you need MDs and DOs to also collaborate with physicians for more experience, more rigorous residency programs, some procedural issues, but also just in general, I think the insurance barriers, like I come back to all the time, plays a big role as well. So you need that collaboration. But you do the patient an injustice, I think, if you go either way. If you go without a physician, right, as collaboration, I think that's an injustice to the patient. I think if you do it without a PA or NP, I think it's also a bad thing for the patient. So I think if you can put them both together and you keep an open mindset about it, that's the best thing. I think, when we started this podcast, I'm going on a tangent here now, we said, hey, we want to talk about just things that are controversial, things that we feel like are really big impact, across the board, that we've seen problems, good things, bad things across the board.
And educate along the way.
Yeah, for sure, right? I think that this is one thing where all of us that listen to this maybe see a clip or whatever that comes through it, whether you're an NP, a PA, DOMD, therapist, whatever kind of care, therapist, counselor, wherever you are at, psychologist. It's the idea that we should all work in better unity than I think we have, right? Sometimes it's kind of like, oh, that's like their clinic, that's like our clinic, this is like not my area of specialty, or we shouldn't work together. But if we all kind of go in on the same mindset that we can work together with it, I think it's the best quality of care you can get. And in fact, everyone wins. The business, the provider, the patient.
I really appreciate that. It boils down to collaboration.
Yeah.
And what you're talking about, having there be unison or unity amongst all the different parts of a care team is so important and something that should be welcomed in any subsection of healthcare, mental health being principal amongst them. Being able to collaborate with an OB-GYN when a female client is pregnant, collaborating with a neurologist for a client that has an underlying seizure disorder or headaches or migraines, you name it, being able to work closely with a gastroenterologist for somebody who doesn't metabolize medications the same way. It can go a long ways towards the outcomes that a client is going to face, right? So whether that individual that you're working with on the other end is an APP or it's an MD or a DO, we know that we're going to be able to get a quality of care that's going to be commensurate with what we're hoping to offer.
Yeah. And I would argue that a lot of mental health is also speed of access, right? Speed of the initial appointment. If you can get patients in a lot faster, I think, just clinically from my clinical experience, I don't have a study I can tell you about, right? But I think that helps eliminate a lot of the issues that come into play. If you let people kind of like fester in their negative thoughts for weeks or for months, sometimes to get in. I mean, a lot can happen in that time frame, especially with kids, right? Like it causes them more turmoil in school or at work. It's hard to recover from those issues if semesters, what was the semester, 4 months, right? 3 months?
Roughly, yeah.
Yeah. And you spend half the semester struggling because of depression, anxiety, or ADD, whatever the issue may be, or sleep, right? And then we get you in. Now it takes us another month to figure out what med works. If you're lucky, a month is pretty fast. We wasted the whole semester. You only have 8 semesters in high school. So what are we doing here, right? It's like, get them in faster. Let's get this process started faster. It makes our job easier. It makes their life better. It helps reduce costs, like we talked about earlier as well. So I think that it's just, if you don't work hand in hand, or I would argue if you don't incorporate PAs into a practice, NPs included, I would argue, right? Pretty simply put, it's very hard to increase access to care. You can't maintain it. I would love to say, hey, yo, I could do 10,000 patients myself. You can't. Like, you got to know what's practical, right? To provide quality of care, to not say, hey, I'll see you again in the next year or in 6 months. And we were talking about this earlier. I think you and I were off the cuff. We were saying that, we talked to a lot of providers, a lot of clinics across the board, and they're like, man, we can't get people in. We can't get people for their follow-ups in. I got to see them again in 2 months. I can't get them any faster. I don't know if I necessarily agree with that. Like, you should always be able to get somebody in. Yes, overbook. Yes, work a little bit later. Yes, have someone else on your team. You should always be able to get somebody in 2 weeks or 3 weeks or a month if they need it. Maybe that's just a norm that you and I have always done. We're like, we'll just make it work. We'll figure it out. But that's something that, like, especially mental health care, you have to be able to say, I'm starting on a medication, or I'm not going to start your medication, and I'm going to see you in 2 weeks.
We're going to make the exception.
Yeah, the office says your schedule's full. Just put them in. We'll figure it out.
We'll do it.
I'll do it to my lunch. I'll double book them. I'll see them in the evening.
And that's something that I love about APPs. I think you're universally met with individuals who say, I'm ready for the challenge. Bring it on. I understand that I'm going to maintain a large caseload. I understand that a lot of people, I'm going to be responsible for their mental health care. But we have such a team that these individuals are up for it. They welcome it. They thrive on it, I would argue. And it's nice to see that hunger and that drive to be the absolute best provider you can be, so that the individual may inadvertently call you Dr. So-and-so, and you say, you know what, I'm actually not a doctor, but I'm going to offer you this quality of care that you're not going to care what my credentials are.
Right.
I'm going to make sure that you're met with patient experience, with evidence-based practice, with the absolute best and brightest. Yeah. And we're always going to do that for you.
And I don't think this is a topic where we're saying, hey, like, you don't need an MD or DO. Not at all. Like, we have, I would argue, one of the most supportive physicians, MDs that I've met before, right? Dr. Mean, hopefully get him on here soon in the future. But one of the most supportive guys for APPs and for patients and for quality of care and access to care, right? So I wouldn't say that most are like that necessarily from my experience, but a lot of them are.
Absolutely.
And a lot of them really get it, and they really want to work together. And if they don't get it, a lot of them are willing to, like, just say, hey, I just need to know how we can work together. I haven't done it before. My residency or my training didn't have a lot of PAs or MPs there. So, hey, tell me, how does this work? How does billing work? How does signing off on charts notes? Who will see the patient? Like, all that kind of stuff. So I think that is very important, right? And there are a lot of good physicians out there that are just super, I guess, aggressive, I would use the word, right? In saying, hey, how do we work together? How do we come,
That openness, that willingness to be like, okay, how does my practice adapt and have a PA or an NP in it? Yeah. What does that look like? Right. How do I figure that out? How is it built? How is this going to work cohesively?
Yeah.
Right. I do want to bring up one thing. I think we'd be remiss to not mention this as we lay out the landscape of what PAs and NPs, how we operate within this field. And again, it's neither here nor there, but we'd be remiss to not mention that there are still limitations in Michigan for what PAs can and cannot do as it pertains to mental health care. Can you walk us through a couple examples?
Yeah, so off the top of my head, honestly, I probably should get more prepared. I don't remember every single, we were talking about this last year too, about some bills being passed, right, or trying to be passed for PAs. I know we have some colleagues out there that probably know it better than we do, but, some of the stuff turns into, billing psychotherapy as an add-on code, right, compared to a psych-trained NP, for instance, who goes to that specific division. We may have the skills, we may have the certificate, we may go through the training course to be able to do CBT, DBT, or a psychotherapy-based, add-on code to your medication management treatment. But because the PA profession was created after the mental health code was written in Michigan, we can't do that.
We're not included.
So we're not included. PAs technically are not included as mental health providers in the state of Michigan as of today, as of right now. I know we tried to change it a couple years ago and then last year and stuff like that, but with COVID and stuff, there's been apparently more pressing matters that get to the front, to the front burners versus the back burners, right?
And it's delayed it.
And delayed it, right? So I try to push one of them to go through too because I think it just improves access to care. No one's saying to give us more rights by any means, no, but we're already doing mental health care, right? So if I'm seeing you in the hospital, and this might have changed now, but it was like that before where we couldn't cert a patient in the hospital, that was a big issue. It's like, well, I've been seeing them for 3 days. Now why can't I cert them? I know the case. Some small things like that, just they play a big role. And then when you're not listed as a mental health provider on the Michigan Mental Health Code, or whatever it's called, the Michigan Code, it then affects how insurance carriers can then say, oh, well, you know what, you're not listed as a mental health provider, we're not going to reimburse the service. It's like, well, I'm providing the mental health service already, I've been trained to do it, and I've been doing it. And I do it for all the other insurance companies. So it's like, it just creates barriers, but who that affects is the patient, because they may switch insurance carriers because their job changes, right? So they go from Blue Cross to whoever they want to go to, vice versa, right? Not to name insurances here, but you change insurance, it's normal. And then that secondary insurance, the second insurance they change to, may not actually recognize a PA as a mental health provider. Now that cost burden goes to the patient. So all we've done is make it more challenging for the patient to, again, like I always say, and everything I've been saying today, I guess the whole day, has been access to care. That's probably one of the biggest things I think that I've seen in the last couple of years, I would argue, as far as the current state dynamic issues with the PA.
Now clarify for me. When we talk about the mental health code, so we know that we're sharing this information with other individuals who are just as interested as we are, because we're not listed in the mental health code doesn't mean that it's a deterrent to us being able to work in mental health. We should specify and clarify that PAs are authorized and can work in the capacity of a physician assistant or a physician associate in behavioral health settings, whether it be inpatient, outpatient, interventional, you name it. Correct?
Yeah, correct. I'm not saying don't go and work in there. I'm just saying that there are some annoyances and nuances that happen with just some billing codes, which is just kind of more the intricacies of it. But no, I think that it might have actually deterred some people back in the day, I think, maybe to go towards it. But no, I would argue that as a PA, like, I wish I knew about it before, or psychiatry before. Maybe I took my first job. I mean, I have I used to work in the ER, like you said, you worked in internal medicine. I used to work in the ER, and I loved it. And I loved doing what I was at and where I was working. And I think the staff, and especially the MDs and DOs that were there, trained me a ton, and they taught me a lot that I know. I just wish that I would have understood coming out of school, maybe, hey, like, there are more avenues, more availabilities in psychiatry. This is what you can do. The autonomy level changes, so on and so forth. And it's hard because luckily we fell into it together. So it's like it kind of fell into our lap a little bit, right? Where it worked out, you kind of ping pong around jobs and you get somewhere like, oh, this is amazing. Where you know that there are many clinicians that don't get that opportunity, but they're not educated on the idea behind it, right? So I think that's the hard part about it. But yeah, it's not a deterrent at all to get PAs to understand, like, yo, you can work in mental health. And there's a lot of avenues, a lot of areas of mental health you can work in. CMH, outpatient, FQHC, inpatient, wherever you want to work at, right?
If there was a listener out there who is either A, mulling going to PA school, or B, is close to being a new grad, okay, someone's considering getting into medicine and is interested in this field, what would be your number one piece of advice for them?
That's a hard question, bro.
I'm putting you on the spot.
Yeah, what the hell kind of question?
I'm doing it on purpose.
I don't know. Drink coffee.
Okay, that's a good one.
No, I think what is my number one advice for them?
Yeah.
And they want to go into mental health?
They're just a new grad PA or mulling going to PA school. What would be your advice for them as they either enter PA school or as they come out the other end as a new grad, entering into medicine as a whole?
So I think if you're entering PA school, I think I would argue that most people going into PA school or in PA school are like, I want to do procedures. Like, it's like, I think I heard everyone say that in school, right? And you have your bougie things that people think are like awesome, plastic surgery, dermatology, like, for sure, they're awesome fields.
Aesthetics.
Yeah. Definitely. So I would say keep an open mindset on which field you want to go into. Definitely go into them. Don't pick your elective rotations to be in your basic things, try to do something. I did my neurology, for instance. I was like, oh, this is pretty cool. Definitely see different fields. I would say use all the connections you can use. All the friends, all the families, all the colleagues, the neighbors, people at church, whatever you got to do. Try to follow as many people as you can follow. And don't just ask them, like, oh, what do they do daily basis? See where they're at. Are they in a private practice? Do they work in their own practice? Do they work for a hospital system? Where are they at? So you can see. I'm not always saying finances matter 100%, but you want to also know how it affects you in the future. Just like I tell counselors, I say, hey, like, you should know if you're going to be an LMSW or an LPC or an LLP or a psychologist, how it changes your insurance carriers and where you can work in your future. You don't really know until you get out. And you're like, what? No one told me this. So I would tell the new grads that, hey, keep your minds open on what fields you want to go into. You may have your favorites, totally cool, but still try a couple other ones, unless you really know you don't want to do it, right? And then you make a decision. And then when you come out as a new graduate, don't take your first offer. Don't be stressed when all your friends get offers in some of the rotations, some of the fast rotations. Ask for references when you take, I didn't do that either, but ask for a reference when you take a job. Obviously, if a hospital is a little bit different, but like a private practice, hey, can I ask like some of your staff members would like to work here? Like those kind of things I think would make a big difference. And then understand that like, hey, negotiations and stuff like that for pay are important as a new graduate, but understand there's a huge learning curve. Like and you're not gonna need to like float. You got to figure it out.
You're going from book smart to street smart real quick.
Completely different. There's no one there hand holding in the back end. Like, so I argue that sometimes like you got to have it kind of have it, right? So you need to kind of get it figured out as far as that point when you get started on it. There's not a lot of hand holding. Some jobs maybe have more than others, fine. But at some point you got to cut the safety net. You're going to have to kind of figure it out.
Absolutely. I would riff along the same lines there. Explore your interests, right? Don't just think that because everybody's going into family medicine or surgery or ER, you have to do the same. Explore your interests.
Yeah.
There's so many different subspecialties out there, and there's so many different fields that can call to you, or maybe that could be your calling. So try it. Be open to it. Similarly, I had two electives that were really profound experiences for me, even though they were only 2-week rotations, and I learned a lot.
What was your elective in?
Urology was one of them. And the second one was like a wound debridement center. And I felt like I learned a lot about hyperbaric treatment and again, wound care in general. It was fascinating. I really enjoyed the experience, and it was something that I really took a lot home, though it might not have been something that was keenly interesting to me off the top, right? One thing I want to mention about the PA field is flexibility as well. So usually when you go to school for something, you're going to go into a specialty, right? Mm-hmm. So such as med school, you declare a residency, like a path, and then you're on that path. For PAs, we're able to switch from one specialty to another pretty seamlessly. Clearly, there's going to be medical training that's required. There's going to be onboarding, and there's going to be a lot of learning on a job. But if one wanted to switch from urgent care to nephrology, they would be able to apply for that position, be trained appropriately, and then start working with a nephrologist, right? That was something that drew me to this field, is being able to have that flexibility. I didn't know if I wanted to do internal medicine for the rest of my life. Clearly I didn't, but now I know psych is my passion. But it took me internal medicine, urgent care, then psych to arrive at that point.
Yeah, that's good. I mean, that's kind of why I picked it too. I think a little bit, I didn't know what I wanted to do. You want to do procedures, you want to do stuff when you get out of school, and then you don't know, like, do you want to do this for the next 30 years, right? So it's definitely important to kind of understand that, being able to change professions, or not professions, but change fields is really important. Sometimes it's not as easy to change. Obviously, we've seen that happen many times before, and it doesn't mean you just change because it's easier. Sometimes you want more of a challenge. But yeah, that's a really good point about it. I think that's a very, very big point. And we've seen a lot of that happen lately with COVID, with mental health. A lot of prescribers want to come from other specialties into psychiatry because they see there may be more flexibility or more autonomy, or the demand is so high, or location-wise, a little bit, because the demand is so high, you can kind of work near, closer to home, or more, more accessibility. Mm-hmm. So I think we've seen a big push of that too, right? Lately, just even at PR, for instance, we've seen that.
I appreciate the influx.
Yeah,
I'm glad that there's opportunities for APPs in behavioral health settings, whether it be, again, inpatient, outpatient, interventional, CMH, you name it. I'm glad that there's space for us to grow a little bit and get more experience, and to be able to show, demonstrating on a day-to-day basis that APPs can offer what needs to be done for the clients.
Right.
It's not just a psychiatrist-run realm anymore, or psychiatrist, psychologist, and nothing against those credentials. There's phenomenal psychiatrists and psychologists out there, but I just think there's space for us. There's space for PAs and NPs to make some difference as well. And I'm appreciative of that. I'm glad we're in when we're in. I always look back and I think fortuitously about when we started Pure, and I'm glad that we're affording this opportunity for a large group of NPs and PAs to be able to make a difference, to reach more people, to be these extending pieces in care, and especially in mental health care.